So now, management of astigmatism, we will discuss about the intraoperative tips and complications, post-operative monitoring, and managing of the residual error. So,
These are some intraoperative tips which prevents rotation of toric lenses. Proper size of incisions. Main incision and side ports should be little longer. Shorter tunnel may cause leaky wounds and AC collapse. CCC should be smaller, round and central. It should be between 4.5 to 5.5 millimeter so that there is capsular coverage from all sides. Complete viscoelastic removal from front and back of the lens. Hydroimplantation of toric IOL is better option. Tilt the lens, move the irrigating cannula behind the lens and wash all the viscoelastic properly. Fill the AC with air bubble and nudge the IOL to the posterior capsule. After hydration of the wounds, form the anterior chamber by VSS. Avoid overinflation of the AC. Remove the speculum slowly. There should be no pressure on the globe while removing the speculum. Patch the eye for 2-3 hours. Use hydrophobic acrylic lens as they are having high adhesive property.
though every time we will not get the uneventful surgery, sometimes there are complications. These are some of the complications. We will see how we will manage these complications. So when we are doing manual marking, there may be a smudging or wipe out of the marks. So when we will shift the patient to the OT, before shifting the patient to the OT table, you check the pre-operative reference marks. So if reference marks are not there in the OT, even in the OT, let the patient sit. You can do 0-180 degree marking. Freehand marking is possible. As Dr. Supplins told, that it is better to use 26 number needle for pre-operative marking because they will last longer and they will not wipe out. So we can overpower this problem by using 26 number needle for pre-operative marking. If CCC is extended more than 6 millimeter, it may happen in hypermature cataract or sometimes patient move his eye when we are doing CCC. So if extension is more than 6 millimeter and if extension is not in the toric lens axis, then you can easily implant the toric lens. If it is in toric lens axis and it is extended up to equator, then better to not to implant the toric lens. If the CCC is smaller than 4 millimeter, in young patient, later on there may be capsular phimosis which can cause lens tilt. This is the very dreadful situation when there is PC rent in toric lens. So if there is a small PC rent in the center and you are able to convert it into PCCC, then it is better to convert it to PCC and put the lens in the bag. If it is oval, then do thorough anti-vitrectomy, put the lens in the bag, and it is not in the steep axis of the lens, then only you can put the lens. Otherwise, don't put the toric lens, you can put the monofocal lens because you can put the monofocal lens haptics in the, not in the extension of the PC rent. Sometime when we are very unlucky, so when we are washing the viscoelastic behind the lens, then there may occur the PC rent. So if the PC rent occur and there is no disturbance of the hyaloid phase, just put the air bubble and don't do any extra maneuver. If there is vitreous in the anterior chamber, so better is to do pars plana vitrectomy. If you will go do anterior vitrectomy, there may be more vitreous will come in the anterior chamber and less dislocation may happen. For intraoperative miosis, as you know that you can use iris hook, rings like Meligan ring, B-hex ring, whatever is comfortable in your hands. When there are weak zonules, there are two types of conditions for weak zonules. It may be traumatic, maybe iatrogenic at the time of doing phaco or washing the, during IA or removing the cortex. You may mistakenly hold the anterior capsule, or it may be traumatic. In these cases, if the zonal dialysis is in 1 or 2 clock hour, you can put CTR ring, very easy to put the CTR ring, but avoid putting the CTR ring if the case is of pseudo exfoliation, because in future there may be displacement of lens back complex and use of CT segment. If you are having confidence enough and you are having posterior retinal surgeon backup is there, then you can go for the CTR ring or something. When there is extend back, mainly in the high myopes, so in this type of cases, don't use the plate haptic lens because they are prone to rotate. So whether to use CTR in extended back high myopes or not to use, so there is one study, and the result of the study is there that there is no statistical significance by putting the CTR ring. Some experts, they are saying that when we put the CTR ring, it will extend the back and lens will rotate more. So they are saying don't put the CTR ring, but don't overinflate the anterior chamber. So if anterior chamber is overinflate, the lens will freely move. So the pressure in the anterior posterior chamber will be equal. So the anterior and posterior capsule, they will in opposition with each other, and they will prevent the rotation of the lens, and keep the patient admit for 2 to 3 hours in the hospital and pass the eye. And before discharging the patient, you can check the patient on the slit lamp. Intraoperative misalignment is also possible. These calculators, they are having, when you will enter the axis wrongly or enter the wrong, if the difference between the steep and flat axis is not more than equal 90 degree, then the calculator will tell itself that there is some error. But what happened, main mistake is that keratometer, in spite of flat, you are optometrist, he will enter the steep axis, in spite of steep, he will enter the flat axis. So total 90 degree difference is there. So in your one suggestion is that in your case papers, you enter the keratometer data. With that, if the autograph reading is possible, some patients, those who are not having very mature cataract, autograph reading is there. So steep axis lie in the plus cylinder, and so that will also give you an idea of where is the plus cylinder and where is the steep axis. So flipping, we are putting the lens in the steep axis, we are putting the lens in the plus cylinder of the autograph reading. So post-operative monitoring, so maximum rotation occur in first 1 to 2 hours. So you can pass the eye, those who are, you are suspecting that rotation may occur. So if proper coverage of lens is not there in all the on sides, you can pass the eye, keep the patient for 2-3 hours, then you can discharge. If after 1 week patient came to you, patient is not satisfied with his vision, vision is less than 6/9, and there is misalignment more than 10 degree. Some patient, they are not bothered about this, their vision may be less, but they are not bothered. So don't try to tell them that there is you can locate the, or you can again rotate the lens and decrease the refractive power. And one thing I will try to tell you, that you can add one sentence in preoperative counseling, that presently you are putting the lens, you are just targeting the power of the, you are correcting the power, you are not correcting the axis. So after 7 days you will I will take you in the operation table, and then I will adjust the axis. So if by chance there is need to realignment, so patient will not think that you are doing surgery again, there is some complication. So that you can add in the, that sentence you can add in the pre-counseling. So realignment, what is the option? If there is residual error, so if the toric lens, there is residual error, how we can reduce the residual error? So one is the realignment. So in which condition realignment is possible? In 2 conditions it is possible. One, the spherical equivalent should be less. And second, if the axis of the current axis of the IOL is on the is on the steep axis of the cornea, then there is no use by realignment of the lens. So spherical equivalent should be less, and toric lens should be not on the steep axis of the cornea. In the case 1, the spherical equivalent is minus 2.62. So by rotating the lens, you can just decrease the cylindrical power. You are not going to improve the visual quality of the patient. In the case 2, the spherical equivalent is minus 0.5. So you have to check the position of the current position of the lens. If it is not on the steep axis of the cornea, realignment is possible. So for check how you can measure the current axis of the toric lens, it is very easy. So make a slit, dilate the patient, make a slit, adjust it on the mark of the lens, and there is a compass, rotating compass in the upper part. So you can check how much is the axis. If you are having retroillumination mode in your autoref, you can take the retroillumination picture, and by using the compass you can also mark this. You can find out how much the current axis of the toric lens. Eye trace is the very good instrument to measure the current axis. It also provide you, do the abrasions at the corneal level, at the lens level, and also provide you how much axis rotation is required. So, but it is very costly instrument, not able to all of us. So for realignment, there are two formulas, formula available to us. One is astigmatismfix.com and second is Barrett RX formula. So we will compare these two. In the astigmatismfix.com, you have to enter only post-operative refraction. Then what is the current position of the toric lens, and what is the power of the toric lens you have implanted. So, and the result you will get, how much will be the realignment axis. In the Barrett RX formula, addition to this, you have to add pre-op keratometry, their axis, axial length, ACD, lens thickness, incision location, and incision SIA, all these things which you have entered in the laboratory calculator. So no addition data is required. Whatever you have added in the, whatever you have entered in the, where you have done calculation during calculating the toric axis of alignment, Barrett toric calculator, you have to enter all data. Extra data is only one, post-op keratometry. So you have to enter post-op keratometry. It will provide you two additional results. One, you will get the exchange IOL and piggyback IOL. Realignment of the toric lens to the new axis, when should be done? You have to done as early as possible if there's gross error. So there is transcription error, 90-degree flip is there, then do as early as possible. So late, more than 2 weeks is advisable if there is, in the high myopes, the bag is very large, and if you realign, you can rotate. So let the bag shrink a little, then after 2 weeks it is advisable to realign the lens. So how you can realign the lens? It is preferred that you use only the bimanual IA and realign the lens. If it is more than 1 month, then visco separation is needed because there are adhesions. So if realignment, these are the options to correct the residual error. Realignment, if realignment is not possible, IOL exchange or piggyback IOL. If you are having access to the LASIK laser, then you can go for corneal ablation procedure also. So I want to compare the Barrett with the astigmatismfix.com. Consider this is a case in which post-op refraction is -2 diopter spherical with +3 cylinder. So when we enter the data in this Barrett toric calculator, it provides us that there is rotation from 60 degree to 105 degree. So if we rotate the lens from 60 to 105 degree, it will decrease the refractive error. So it will also give the how much refractive error will decrease, and at the same time the upper part, left upper part, it is also providing us that if we want to change the lens, so what will be the power of the lens, new lens, and what will be axis of the new lens. And the second picture, it also provides us the piggyback IOL. If we don't want to rotate the lens, we can put the piggyback lens, and what will be the power of the piggyback lens and its axis. But if the cylindrical error is there, cornea is cylindrical, toric lens is cylindrical, and if you want to put cylindrical piggyback IOL, so it is a little complicated, there will be complications, so better to go for lens exchange. This is astigmatismfix.com. In this only few data are required. It gives us the how much rotation of the current IOL position is 60 degree, ideal IOL position is 104 degree. Here it is telling. So how much rotation we have to do, and what will be the residual refractive error. It is telling us only two things. Let us compare these two calculators. So in the astigmaticfix.com, in the same case, if I am taking ACD 3 millimeter, so it is telling that axis of IOL is current, you have to rotate it to 104 degree and residual will be remain 1.05. If I enter this data in Barrett will tell that you have to rotate the lens to 105 degree and residual will be 1.11. If I increase the ACD from 3 to 6 millimeter, considered as a hypothetical case, so there will be no change in the astigmatic fix axis, new axis and residual, because it is not considering ACD. But in the Barrett, previously it was 105, now it is 107, and residual will also increases from 1.11 to 1.35. So axis rotation is increased and is changed by 2 degree. This is due to the ACD. So these parameters are not included in the astigmaticfix.com. They are included in the Barrett. So Barrett is anyway better than astigmaticfix.com, but data entry is easy because only 3 data are required to find the new axis of alignment in the astigmaticfix.com. So that is easy to use, but it is better to do the Barrett RX. Thank you.